We will now proceed to the full clinical examination of the musculoskeletal system that will be adopted by the veterinarian. This will be a more thorough examination than that which can be conducted by the greyhound trainer in the hustle and bustle of kennel world. But the veterinarian will normally approach the greyhound standing on the floor, which gives you a better opportunity to examine the entire body. We again check the cervical vertebrae for any displacement or any reduction in the range of movement. As the head adopts the full range of movement, you'll also detect major injuries to the musculature of the neck. Having done that, grasp the wings of the atlas and check that atlantoaxial joint, which may be damaged during trauma and falls of the racing greyhound. Onto the cervical musculature, we have the cervical rhomboids, omotransversaris, and brachiocephalic. The sternothyrohyoids, the superficial pectoral, and the deep pectoral. These are palpated using a thumb and finger pressure of 12 to 14 pounds, which you can check on the bathroom scales to see that you are using sufficient pressure and not using excessive pressure. When we palpate the muscles, it's customary to run round the edges of the muscle and then over the central part or belly of the muscle. So we've checked the ascending and transverse branches of the deep pectoral. Moving on to the shoulder, we'll feel the spinous process of the scapula, then move on to the supraspinatus muscle, and then the infraspinatus muscle just behind the spine of the scapula, and then over the deltoid, the upper portion of the deltoid. When you reach the acromion process, we can feel the acromion section of the deltoid. Then run over the three parts of the triceps muscle which are palpable. The upper portion, which commonly tears away from its attachment to the posterior border of the scapula, the remaining portion of the long head of the triceps, then the lateral head of the triceps. Move on to the latissimus dorsi, and then the thoracic rhomboids. After the thoracic rhomboids, with the fingers, you can feel the trapezius muscle as it crosses across the top of the scapula. Now we check again the range of movements, elbow to the level of the saddle area. Then the veterinarian will just check the biceps brachium to see that there is no disruption of the transverse ligament holding the tendon in the bicipital groove, flexion of wrist and elbow joints, and full extension, noting that the foot extends so that there is no damage to the common digital extensor or the extensor carpi radialis. We can now move along to examine the vertebral spines in the thoracic and lumbar region. The damage that may occur here is that if the body twists forcibly, the articulation at the base of the spinous process of the thoracic vertebrae may become out of line, and in that case the downwards pressure will cause quite severe discomfort. Checked with the side of the hand, the soft part of the hand, pushing down on those vertebral spines. The last of the lumbar vertebrae, L7, check the supraspinous ligament. Sometimes that becomes detached. If it remains detached for a number of runs, the spinous process of L7 will actually sustain a fracture. The fracture ends up about the size of the human thumbnail. The reason for that being that the longissimus lumborum muscle takes its origin from the medial aspect of the ilium and from the lumbosacral fascia and the spinous process of L7. So as the greyhound changes direction on the turns and even on the straights at high speed, the irregular pull of the left and right side moves the spinous process of L7 to the stage where stress fracture occurs. And this, of course, reduces performance out of the boxes and when the greyhound changes direction. Having done that, we'll run along the longissimus system, the longissimus thoracis, again, the medial and lateral aspects of each of the muscles and over the belly of the muscle. Having done that, we check the area between the last rib and the hip, which is the longissimus lumborum and the iliocostalis and the iliopsoas, and of course you won't get as far as the quadratus lumborum. But you may detect quite severe pain and discomfort or even fascial tears in this area, and they can have a major consequence on performance. Then the external abdominal oblique is palpated from its origin on the last few ribs to its fascial insertion all the way along. Now we move on to the hind limb area. The sacrotuberous ligament, which is sometimes subjected to quite severe tears, and the gluteals, the superficial gluteal and the middle gluteal. Onto the sartorius, the tensor fasciolata, and then the quadriceps group, lateral vastus, medial vastus, and rectus femoris, and vastus intermedius is too deep to be palpated, but would not sustain damage without major damage to the other three components of the quadriceps. Then move the hand inside to feel the femoral artery and the femoral triangle. Just behind that, you feel the pectineus muscle. Having felt the pectineus muscle, you then visualize, just lift the limb and look at the opposing side. The skin is transparent on the medial aspect of the thigh of the greyhound, so that any trauma can be detected quite readily. It also gives an opportunity to see if there is any lactation, or if we have any other infective processes going on, which commonly occur. You'll find little staphylococcal infections occurring on the thin skin of the ventral abdomen or the medial aspect of the thigh. Having done that, we'll move to the rear part of the limb and examine this section. For that purpose, I'll just turn around to make it more convenient. Now, first you elevate the tail and we'll see if there's any sign of estrus in the female, any vaginal discharge, any virilization from the overuse of hormone, or if we have any testicular abnormality in the male. The gracilis muscle is palpated from its origin of the pubic symphysis to its fascial insertion on the interface with the semitendinosus, or on the tibia, or over the medial head of the gastrocnemius onto the Achilles tendon. Gracilis. Then the hamstring, which is semimembranosus and can be palpated from the ischial tuber down a distance of about 4 or 5 inches, and the semitendinosus. When we reach the bottom of that area, you'll feel the popliteal lymph node. Any swelling of the popliteal lymph node would indicate infection or inflammation of the lower limb and will cause for closer examination. The next section we deal with is at the region of the calf, which is composed of medial and lateral heads of the gastrocnemius and the superficial digital flexor. Medial and lateral heads of gastrocnemius are palpated, and the superficial digital flexor with thumb pressure directly from behind. Achilles tendon palpate. Any swelling or irregularity will indicate damage to one of the 3 components of the Achilles tendon. Where the lateral saphenous vein crosses the fibula should also be palpated, because this is a common site of fibular fracture. We then examine the full length of the fibula and the cranial tibial muscle. Thumb pressure on the cranial tibial muscle. At this point, raise the limb and examine the main pad and the digital pads for any penetrating wounds, the ventral web, or any splits or tears which commonly occur under the deep flexor tendon, or any damage that may have occurred to the skin covering the joints of the metatarso-phalangeal area, commonly associated with bed sores, sometimes trauma on the track. Now examine the anterior part of the foot. Raise the foot and check the nails for split nails, infected nail beds, paronychia, split web, sprained collateral ligaments, commonly known as sprung toe, or dislocated joints associated with disruption of the collateral ligaments. Check the full range of movement of the sesamoid joint, the metatarsophalangeal joint. P1, the first phalanx, should be at right angles to the metatarsal bone on each of the toes. When you check that, make sure that you apply pressure to the distal end of the first phalanx, that's the middle toe joint, not to the nail. If you push on the nail, the toe will merely roll up and you won't achieve that right angle bend between the first phalanx and the metatarsal bone. Then we palpate the metatarsal bones, feeling for periosteal thickening or any sign of callus or irregularity on the surface of the bone. We now examine the soft tissue structures around the Hock joint. The Hock joint itself will be subjected to trauma, particularly on the turns when you have redistribution of body weight. A finger and thumb are used only to turn, as we suggested previously. The finger at the back of the bottom end of metatarsal 2 and the thumb at the lower end of metatarsal 5, and rotation is applied with sufficient force to move the stifle. Now, having completed that portion, we must check the insertion of the cranial tibial tendon on the proximal end of metatarsal 2, and that's achieved by straightening the Hock completely. A full straightening of the Hock to check the insertion of the cranial tibial tendon. Flexion of the joint with the pads in the palm of the hand, the other hand on top of the stifle, and note the distance between the toes and the stifle joint on this side, and then the same procedure is adopted on the other limb, and if there's any disparity we must diagnose the cause. Most commonly it will lie in that section, either damage to the metatarsal, to the Hock, to the Achilles tendon, or to the muscles of the calf, the medial and lateral heads of the gastrocnemius, and the superficial digital flexor. All that remains now is to complete the examination of the stifle joint and the hip joint. The stifle joint is flexed, extended, and rotated. Stifle joint injuries are uncommon in the racing greyhound, although they do occasionally occur. Mainly they'll be detected as pain on flexion and extension with swelling just posterior to the distal patellar ligament. The hip joint is examined by full extension using one hand on the hip to maintain balance for the greyhound, the other hand on the stifle, and raising the leg just sufficiently so that the other foot comes off the ground. We then grasp the lower limb and bring the toes forward to the level of the shoulder joint. The final examination of the hip joint requires elevating the limb sideways with the opposing hand on the hip to support balance. That procedure is then undertaken on the opposing side. In this particular case, we've examined the right side of the body. You would then move on, usually to the left hind limb, the left coupling area again, and then onto the left shoulder and lower limb. Whatever procedure you use is at your own discretion, provided you examine all of the musculoskeletal system that is accessible to palpation. We are looking for areas of myositis, muscular soreness and bruising, the second stage of muscle injury being tearing of the fascia, and the third stage of muscle injury, which is disruption of the muscle fibers. Third stage injuries are usually those detected by the trainer and presented to the veterinarian for repair processes, either surgical or using physical therapy. The veterinarian will be able to detect injuries at an earlier stage and adopt a preventive medicine program to the benefit of the greyhound trainer. I do hope that this video has been of some help to you, and that your greyhound racing careers will extend and benefit from it.
Very clear and concise manner, Dr. Gannon has explained and shown to us a method of systematically evaluating the racing greyhound for soundness. This enlightening video has covered a vast amount of information and special techniques that should prove extremely useful to the veterinarian, the student, the trainer, the handler, and the owner breeder. If you now possess this tape, we recommend that you review it over and over. Each time, you will note something new that you missed the previous time. We think this video will serve as a lifelong learning source for the lover and the admirer of the racing greyhound.